Welcome to a discussion of telehealth used for improving epilepsy care. The average annual healthcare coverage spent per person in the United States is $8,700, according to the Centers for Medicare and Medicaid Services. This expenditure is nearly twice as much when compared to other developed countries. The agency predicts such spending will reach $14,000 per person by 2021. Epilepsy is the fourth most common neurological disorder in the United States. The condition affects nearly 3 million Americans at an annual cost of $17.6 billion. $1.8 million per year is spent on emergency department utilization expenditures. A majority of the cost is incurred by an estimated 30% of these individuals diagnosed with refractory epilepsy. That is, epilepsy not responsive to conventional medical therapies. Approximately 500,000 to 900,000 of these individuals are diagnosed with refractory epilepsy. As a disease state comparison, this refractory group equals or outnumbers the prevalence of those in the U.S. with multiple sclerosis, new-onset strokes, and Parkinson's disease. A large fraction of individuals in the U.S. with refractory epilepsy are located in rural communities. A disproportionate number of these individuals are either underinsured or have no health care coverage whatsoever. Such disparities impact an ability to self-manage ongoing care needs and adherence to prescribed therapies, leading to increased utilization of health care resources. Consequently, U.S. hospitals may face financial penalties when patients develop exacerbations of their chronic medical conditions while in their care or are readmitted within a short time frame. Enter the Affordable Care Act. Once healthcare reform is fully implemented, 18.2 million of the estimated 48 million uninsured individuals in the U.S. are expected to receive healthcare insurance. 800,000 of the 1.8 million uninsured individuals in Illinois will receive healthcare coverage following full implementation of the Affordable Care Act. This disparity will noticeably impact access to limited healthcare resources. The solution? Telemedicine as a means or bridge for delivering care to a significant number of these individuals. So, what is telemedicine? Telemedicine, as defined by the American Telemedicine Association, is the use of medical information exchanged from one site to another by way of electronic communications to improve the patient's healthcare status. What is not telemedicine? Informal discussions between practitioners by telephone or even teleconferencing technology. So what is the difference between telemedicine and telehealth? Telehealth is the use of electronic information and telecommunication technologies to support long-distance clinical health care, patient and professional health-related education, public health, and health administration. Telemedicine is a subcategory of telehealth. Telehealth can potentially lower technology costs and increase portability. Telehealth is a new paradigm or means to treat those patients by healthcare providers. The patients benefit directly, where traditional delivery of healthcare services are influenced by distance, lack of local specialists, and resources. So when one looks at telehealth technologies between now and 2017, an estimated 1.8 million people will have access to telehealth by the end of this decade. This still falls far short of the 7 billion people on this planet. As of mid-2013, more than 15 U.S. hospitals provide pediatric telemedicine consultations to patients at remote, rural, or underserved emergency departments. The patient, parent, and referring physician are often present for the audio and video interaction with the off-site pediatric specialist. Higher quality of care outcomes are being observed for telemedicine consultations as opposed to phone consultations. The use of laptops, tablets, and other mobile devices are more cost-effective than larger video conferencing systems. One proof of telehealth facilitating care is seen in Alaska. The Alaska Federal Healthcare Access Network, or AFCAN, connects approximately 180 Alaska Native Community Village clinics, 25 sub-regional clinics, 4 multi-physician health centers, 6 regional hospitals, and the Alaska Native Medical Center in Anchorage. More than 3,000 providers have engaged in over 160,000 telehealth clinical consultations since 2001. It is estimated that in 2012, the Afghan telehealth program saved the state of Alaska $8.5 million in travel costs for Medicaid patients alone. Canada has one of the most sophisticated telemedicine infrastructures in the world. Feasibility of epilepsy care through telemedicine is established, but its use by practicing neurologists is underutilized. Canadian telemedicine was mainly used for educational purposes. 79.5% of Canadian physicians had access to video conferencing equipment, and 61.5% voiced a need for clinical telehealth. The main perceived obstacles in the use of telemedicine in Canada were a lack of infrastructure support and reimbursement problems, followed by limitations in physical examination capabilities. So what are obstacles for deploying telehealth in the United States? 2 significant obstacles are state licensure and reimbursement. State licensure rules may prevent providers in one state from treating patients in nearby states. Less restrictive Medicare reimbursement rules for telehealth services are not yet available. The Telehealth Enhancement Act of 2013 has been introduced in Congress recently. It would expand the sites available for telemedicine reimbursements, add incentives for fewer hospital readmissions, and facilitate home-based kidney dialysis, among other items. The Telemedicine for Medicare Act would expand licensure across state lines. Telehealth tools are only recently shown to be effective in coordinating care and in saving time in areas where service access is scarce. However, there is a lack of data that telehealth services improve outcomes. The prestigious Institute of Medicine called for more evidence on telehealth patient outcomes in 2012 through 2013. The possibilities for telehealth are expanding faster than healthcare's ability to use, implement, or pay for it. So where do we go from here? Solution? Telemedicine as a means or bridge for delivering care can actually be called telehealth. However, tele in telehealth is very old. It implies the telephone or telegraph. More appropriately, mobile health or mHealth better describes the new technologies. One of the most fascinating technologies has been implemented over the last 9 years during the NeuroPace multi-center clinical trials. This device, which is an implantable EEG and defibrillator for the brain, had been implanted in over 200 patients with refractory epilepsy. For the first time, practitioners from across the United States can observe the seizure of a patient and fine-tune the defibrillation process to prevent seizures from reoccurring. It is currently waiting for FDA approval. The future telehealth initiative includes developing health information technology-assisted, community-based coordination centers collaborating with large medical centers. Such initiatives can accommodate increased patient numbers following healthcare reform. Such a strategy will allow the development of customized web-based HIPAA-compliant technology for plugging into a coordination center operated by individuals, also called navigators, for matching on-demand epilepsy care and co-occurring conditions such as mood disorders and developmental disabilities. Such technology requires privacy between practitioner and patient. Additional standards for security and functionality include the ability to have authorized administrators to grant or remove restrictions or privileges to users and groups that includes both practitioners and patients, with the ability to log information and perform audits as needed and use passwords with user authentication. In effect, the patient and practitioner are well protected. When this is all put together, what happens is beautiful. Multiple Practitioners and patients come together discussing day-to-day healthcare as well as very sophisticated technologies for surgery. One of the future technologies about ready to be implemented includes sensors. Such sensors are currently used in cell phones. When placed over the body, the patient can be transformed into a cartoon character, also called an avatar. The patient can be followed across the room or across town. The patient can be watched unimpeded by walls or bed sheets, yet still maintaining confidentiality and privacy, since that individual is now a cartoon character. There's nothing wrong with that. These patients can be followed. Their seizures can be observed. The ability to watch seizures progressing across the brain now reaches a new level. Currently, the only obstacle, they're very expensive. You are presently learning from a pilot, computationally intensive production of on-demand animated education. This series is currently under development, addressing epilepsy and mental health. The target audiences include individuals and family members living with epilepsy, as well as healthcare providers. Overall, an animation-intensive distance learning library will be readily accessible at the patient, caregiver, and healthcare provider levels. Such on-demand access to a regularly growing library of media-rich, entertaining educational material will facilitate amplifying epilepsy outreach at a global level. Thank you for your attention.